Hey, this is Brandon with ChiroUp. Today we're going to talk about the shoulder. We're going to talk about 7 things that I think are so important in treating the shoulder. I understand there is a lot of research on classifying and actually diagnosing the specific tissue that's injured in the shoulder. I get that. I appreciate that. I do that every day in my practice, but there are a couple things that you're going to look at independent of the actual diagnosis. For example, how does a scapula move? Do they need scapular stability versus mobility? Do they have specific ranges of motion that are lost? And as it turns out, when you look at the entire shoulder continuum, we see some trends, some things that you can look at regardless of the actual diagnosis, and things that you can do to make an impact on that clinical case. So the first thing is take a look at the range of motion. I know that sounds silly. You should be doing that for every single patient. However, there are a lot of directional preference stretches that you can do to help be adjunctive to your therapy. As it turns out, the number one range of motion that's lost throughout the entire shoulder diagnoses turns out to be internal rotation. So here's a great video on how to look at shoulder internal rotation, how to have a patient do these stretches at home. And I think that if they can improve that range of motion quickly, it doesn't matter if it's a labral lesion versus impingement syndrome, you're really going to have a lot of impact on getting that person out of pain quicker. Now, the second part is talking about impingement. Impingement is probably the number one source of symptoms. Now, the source of why it's being impinged, we can go and debate about that depending on the diagnosis. But there are things you can do to alleviate symptoms and to take away impingement. One of them being posterior tilt of the scapula. You can see here, I'm demonstrating on Becky on how to teach posterior tilt. I think this is one of the most important pieces of the puzzle. It doesn't force the patient into a retracted scapula. It still allows them to go through some upward tilt and outward abduction of the scapula while they're moving through a normal range of motion, but does stimulate and activate that serratus anterior, which is so important in these cases. When we talk about the scapula, that brings me to my third piece, which is look at the scapula. Do they need scapular stability or do they need scapular mobility? Taking a look at this actually scapular assistance test, which you can see here, and then also the retraction test, which you can see here, teaching the person how to actually utilize those scapular stabilizers. Fourth tip is make patient education a priority, making sure they understand what's wrong with them just as much as you understand what's wrong with them, making them an active participant in their care and making sure they're doing their rehab exercise, whether it's stretching or strengthening. Obviously that might be a little better dealt with once you know the specific diagnosis, but make sure they have homework. Next is reassure that patient of positive prognosis. These patients have had this shoulder pain for a while. Let's face it, we don't normally see people right off the get-go. They've had it for a week, a month. People often will take a little bit of time before coming in. Make sure that you let them know, hey, I know what's wrong with you. Here is what it's going to take to get you out of pain. With your best guess, give them a prognosis and what to expect. You should expect to tuck in your shirt better. You should expect to be able to lift your hand at the top of the cupboard. Give them small functional goals to make sure that they understand that they're getting better. Sixth point, rehab. Rehab is probably the most important piece of this puzzle because a lot of these conditions are due to dysfunctional tissue. Most importantly, your tendinosis. Tendinosis issues don't like compression. If they're keeping their arm up and they're using a mouse, if they're sleeping on their shoulder, if they're doing all those things, they're not going to get better. You need blood flow to that tissue. You need to let them heal. So make sure that you're able to eliminate all the things that are causing that person's pain. I tell a story all the time, but I had a patient who worked in an OB's office, and what she did is she did the ultrasound where she'd have her hand on the ultrasound wand on the pregnant patient's belly, and the other hand was on the keyboard. And she constantly had impingement syndrome symptoms on that right side. We switched it up and had her switch arms for half the day, half the patients, and she started to get better. So it doesn't matter what you do in your office as far as passive care, what activities you give them as far as at home for active care, you also have to make sure you're attacking why that person has pain in the first place. And here, is the last piece of this puzzle. And this is the piece that I think that often goes overlooked, is that when you're doing rehab, especially in a tendinosis model, is that they're going to have some discomfort. Don't let them get out of their exercise by saying, well, it hurt. Well, too bad. Now, if the pain's between a 3 and 4 out of 10 or less, then you need to suck it up and we need to remold some tissue. Now, you can say that however you'd like to your patients. We need to be nice and we need to work with them. We need to be empathetic. But in the same token, we need to make sure that we're actually remolding tissue, and it's going to cause some discomfort. Now, if they have pain that's lasting through the night or the next day, you might have done too much, and that's okay. You're hitting the right tissue, but maybe back off the weights or back off the sets. So there's my 7 tips on what I'm going to do. That's my workflow with every single shoulder patient. Now, clearly I'm going to do some myofascial release and some manipulation and some things specific to that diagnosis, whether it's a labral lesion versus a rotator cuff syndrome versus an impingement syndrome. There's different things we can do. Take a look at ChiroUp for those recipes that I use in my practice. But if I had to look at the ancillary stuff, those are 7 things that I think are the most important.